Hello, guys. Welcome to Pete's. Today, we are going to discuss a very important topic: how to approach a child with ptosis. Okay, this is a very important topic to know, and you need to know the scheme for ptosis. That whenever a child presents to you with ptosis, how you are going to analyze him on different patterns. Okay, so before we proceed further, please subscribe the channel, hit the bell icon. So, if you find a child with ptosis, first of all, what you are going to see? Inspect. First of all, inspect the child. Okay. Look for any dysmorphism. If the child is dysmorphic, okay, then you have very narrow differential. Okay. You will be having Noonan syndrome. You will be having Smith Lamely Opitz. Okay. And number third, we have Rubinstein. So if you find a child with ptosis and he has bilateral ptosis, okay, and he is dysmorphic, you should consider these three syndromes. Okay, first of all, inspect the child. If on inspection he is dysmorphic, you go for syndromic features and you will find features of any of these syndromes. Okay, but if you find that the child is normal, okay, then what are you going to see is he having unilateral ptosis or bilateral ptosis? Now this is very important to differentiate, okay, because all the causes, all our scheme will be dependent on this. Okay, so now first of all we will be taking unilateral ptosis. You have found a child with unilateral ptosis. Okay, now the important thing to look after you have found that child has unilateral ptosis is look for pupil. Okay, look for the pupil. See if the pupil is constricted or it's dilated. Very simple. If the pupil is constricted, look for Horner syndrome. You see, it's very simple. You see the child is unilateral ptosis. You see the pupil, it's constricted. Look for Horner syndrome. Now, what are the features of Horner syndrome? There will be an ophthalmos. Okay, the eye will be inward. There will be ipsilateral anhidrosis. And number third is there will be heterochromia. So you found that the pupil is constricted. Look for features of Horner syndrome. These are the features of congenital Horner syndrome. Okay, but you need to know that sometimes the Horner syndrome is congenital, but other time it is acquired. Okay, so you also need to look for acquired features. So now you will look for causes which can cause Horner syndrome. Okay, you will do neck examination, any swelling, scars, okay, lymph nodes. Look for number two. Number one is look for neck, okay, and number two, look for median sternotomy scar. Okay, it can occur post cardiac surgery. Okay, Horner syndrome is common after cardiac surgery. And number three, you need to look for is upper limb Erb's palsy. It can occur alongside with Erb's palsy during traumatic delivery. So you see, it's very simple. If you find a child with unilateral ptosis, you'll look for the pupil. If the pupil is constricted, go for Horner syndrome. Check for the features of Horner syndrome. Either it is congenital or acquired. Congenital will have feature like anophthalmos, ipsilateral anhidrosis, heterochromia iridis. And acquired, look for the cause. What is causing? You look for neck examination, sternotomy score, and upper limb for Erb's palsy. Now, number two, you find that ptosis is unilateral ptosis and pupil is dilated. Okay, so you need to look for third nerve palsy. Okay, third nerve palsy. So what you will find in third nerve palsy is dilated pupils. Okay, dilated pupil, ptosis, diplopia, and divergent squint. Okay, so now you find that the child has third nerve palsy. So you should not stop here. Now you need to look for the what is causing third nerve palsy. You should number one examine other cranial nerves. Okay, in which there is fourth, fifth, and sixth cranial nerve. Okay, these all pass through the cavernous sinus, and if there is problem in all these, you should be suspecting cavernous sinus thrombosis, which is leading to third nerve palsy. Number two, you need to do fundus examination. Okay, so what will fundus examination reveal? Maybe there is papilledema, papilledema due to uncal herniation. Okay, and number three, you will look for head. In head, you will look for scars or VP shunts. Okay, and after all, you will do the neurological examination because it can be lesion can be anywhere. So now we know how we will approach unilateral ptosis. Okay, in unilateral ptosis, the important thing to look for is pupil. Okay, if the pupil is constricted, Horner. If the pupil is dilated, third nerve palsy. Then we are looking for the causes. Okay, now we will come to the if the child has bilateral ptosis. So if the child is having bilateral ptosis, the first thing you need to check for is check for fatigability. So how will you check for fatigability? Okay, you will ask the patient to look up to the roof. Okay, he will look up, ask him to keep looking up. Okay, after 30 second, 40 second, his eyes will be fatigued. Okay, now you ask him that look straight. Now when the patient will look straight, because the muscle are fatigued, the muscle in the upper lid, which is palpebrae superioris, levator palpebrae superioris, it will be fatigued. Okay, and now the ptosis will be more pronounced. Okay, if there is fatigability test is positive, that is After you apply the stress of looking upward to the roof, then the ptosis become more pronounced. Okay, then we will say that it is positive fatigability. And there is ophthalmoplegia. Okay, what is ophthalmoplegia? Ophthalmoplegia is, these are the eyes. When the patient looks to the right, okay, the right eyeball moves to the right, but the left eyeball is lagging behind and moves with a delay. Like this has moved from here to here, so it is here, and but the left eyeball will be still there. Okay, and now it will move. There will be a delay in the movement. So this is ophthalmoplegia. You find that there is fatigability and there is ophthalmoplegia. Now, if you find these two features with bilateral ptosis, you narrow your differential and you can easily say that this is myasthenia. Okay, it's very simple. And if there is no fatigability, if you find that there is no fatigability, okay, and next you look for is myopathic phases. Okay, myopathic phases. Okay, if you find that there is no fatigability but patient has myotonia. Okay, if patient has myotonia, myotonia is facial weakness. Okay, and myopathic phases, we can label him as myotonic dystrophy. Okay, now if there is no myotonia, no myopathic phases, if there is no myotonia, then you'll do the CNS examination. Do CNS examination. If it's normal, it is congenital familial ptosis. Okay, and if you find during your examination that there is weakness, upper limb weakness, shoulder girdle weakness, okay, or winging of scapula. If you find these features, you can label it as fascio scapulohumeral muscular dystrophy. Okay, now it's simple. You check for fatigability. Fatigability is positive. Ophthalmoplegia is positive. Go for Mysthenia gravis. No fatigability. Check for myopathic phases. If there is myotonia, myotonic dystrophy. If there is no myotonia, check for CNS examination. CNS examination is normal. It's congenital familial ptosis. If on examination you find that there is decreased power or weakness of upper limb or shoulder girdle or winging of scapula, it is facioscapulohumeral. Okay, and if you find that with no myotonia there is problem with gait. Okay, if you find that there is problem with gait, now we will be doing, if there is no myotonia, we'll continuing our scheme. Okay, no myotonia but there is a problem with gait. Okay, so in this case you will see what is the gait of the patient. If the patient has waddling gait, okay, and Gower sign is positive. Gower sign depicts proximal muscle weakness. Okay, and there is proximal muscle weakness which is demonstrated by Gower sign. So it is muscular dystrophies, maybe congenital myopathy, maybe mitochondrial myopathy, or congenital muscular dystrophy. Okay, and if you find that in gait the child has high steppage gait, so high steppage gait, this depicts neuropathies. Okay, and in neuropathy you will find more distal weakness. Okay, there is more distal weakness, and if you find generalized decreased or areflexia, okay, so it is GBS, high steppage gait, there is distal weakness and generalized decreased reflexes, GBS. And if there is also ataxia, then it is Miller Fisher variant of GBS. Okay, so now we are clear that if there is no myotonia, then either CNS's examination is normal, then it is familial congenital ptosis. If there is weakness of upper limb or upper limb girdle, fascio scapulohumeral. Okay, I think now that is clear. That's very simple. This is a very good approach. Let's revise. If you find a child with ptosis, inspect for dysmorphism. If there is dysmorphism and there is bilateral ptosis, look for syndromes Noonan, Smith-Lamley, and Rubinstein. Okay, but if there is no dysmorphism, check for whether ptosis is unilateral or bilateral. And if ptosis is unilateral, check for pupil. If pupil is constricted or dilated. If constricted, check for Horner and associated. If dilated, check for third nerve palsy and associated for the cause. If there is bilateral ptosis, check for fatigability. If fatigability is positive and ophthalmoplegia is positive, Mysthenia gravis. And if there is no fatigability, check for myopathic facies, Myotonia. If there is Myotonia and there is facial weakness, there is myotonic dystrophy. If there is no myotonia, CNS is normal, congenital familial ptosis. If there is upper limb weakness with no myotonia, facioscapulohumeral. And if there is gait problem, then check whether the gait is waddling with positive Gower, it's congenital myopathies. If it is high steppage gait with distal weakness, with areflexia, it's either GBS or ataxia. I hope that this is now clear, and if you like the video, please subscribe to the channel and hit the bell icon. And if you feel any difficulty, please do comment, and if you want a video on a specific topic, please mention in the comment below and I will be making one. So that's all for today. Thank you.